Hi, this is Katherine from PINK Concussions, and we're part 3 with Dr. Theis, and we have several questions from our last podcast and some questions that I would like to bring up today. So welcome back.
I'm so excited to be back. Love this forum.
So let's start in with one of the questions that I know you've been getting at your practice. That would be visual snow.
Yeah, we get a lot of calls for visual snow and a lot of questions about visual snow. And I think one of the first things that parents or the patients will say to me is, why can't I find any information about it online? Or why is the information all over the place? Like, I can't find any good resources on it. And so I kind of wanted to bring the conversation I have with these patients online so that everyone can kind of understand what is visual snow and why is it so hard to find good resources on it. So visual snow is a very interesting visual phenomenon that can occur for many reasons, where your entire field of vision has these itty bitty teeny tiny black dots in it. So it looks like the static TV that all of us in the older generation are used to having with the bunny ears. It's funny because the younger kids that get this visual snow don't actually know how to describe it because they don't know what static on a TV looks like. But my older patients know exactly how to describe it because they've seen it before on TV. So that's been a fun phenomenon for me working with different generations. But the field of view is all these teeny tiny dots and they move, and they can increase in how fast they move and how much they disrupt their vision, depending on stress or what they're doing or what they're looking at. And it's incredibly debilitating for patients because it's kind of like they're looking through this film, but the film is always moving. So it's very distracting. And some people are born with visual snow. They've had it their entire lives. And these are some of the kids that I'll get that come to my practice because they have reading problems or dyslexia or ADHD. And then when I ask them, hey, do you have this? They'll say yes. And the parent is like, what? And the problem is the kid doesn't realize because they've never seen differently that that's not normal, that nobody else sees it.
Interesting.
Yeah. So there's some people that are born with it. They've had it their whole lives and they don't know to complain about it until they're older. I have another patient population. A lot of patients who've had a concussion can have, I wouldn't say a lot, but of people who I see with visual snow, a lot of them have a history of getting it from their concussion. We've had a couple of isolated cases where they've had it after an infection, a couple from COVID. I know there's a couple case reports of those in COVID as well that are popping up here and there. Other viral infections have done it. Patients say, I got this bad virus and all of a sudden I've had snow. I've had a couple of patients who had a bad drink, like they drank alcohol and then they had it, but it wasn't laced necessarily, or edibles can do it too, some weed. But again, I've had patients, they come in and they'll say, I split an edible with a friend and I have visual snow now forever and they don't. So it's not like it was laced with something. Like there's something about the brain chemistry for these people that makes them react differently to different insults than others.
Now, does it change throughout the day? If you're tired, it gets worse, or does it tend to, you have it, you're in it all day long?
Great question. And it depends on the person. So every single person has a completely different experience with their snow. Some people have what we call visual snow syndrome, which means they also have other symptoms with it. And so some of the other symptoms are going to be photophobia or light sensitivity, nyctalopia, which means they have trouble seeing at night, which is interesting to have both. I'm sensitive to lights, but I can't see if you turn them off. So having both is very frustrating. Something called palinopsia, which is essentially when you get these smears of visual moving targets. So when a target's moving quickly, it's like you see a trail moving after it. You can also get persistent afterimages. Now, we in normal day-to-day life can sometimes see a persistent afterimage. Like if you look at a light brightly and then close your eyelids, you'll get that imprint of that image on the back of your eyelids almost. And then it goes away. But for people with visual snow syndrome, some of them have afterimages of looking at normal things. So for example, I would look at you, Katherine, and then I would look at the wall and I would have an afterimage of you on the wall. And you can imagine if you had all of these afterimages that wouldn't go away anytime you move your eyes anywhere, it would be so hard to process what you're seeing. And then some other comorbid things, about 50 to 80% of people also have migraine, but this isn't a type of migraine and it's not a migraine aura, although sometimes misdiagnosed as one. Some patients also have tinnitus or ringing in the ears. And then some patients have, we've noticed in our office, it gets worse depending on their neck position, which makes sense with tinnitus. Tinnitus can have that too. And so the part of, well, can it fluctuate throughout the day? It can for the people who it's neck related, in which case when their neck is changing positions, then their snow is changing positions.
I never had ringing in the ears until I got my COVID vaccine.
How was it?
Every time I get a COVID vaccine or I had COVID, I had ringing in my ears. Also very debilitating. It's just, really
everyone is different. Everyone's is different. And the hard part for it, I have some people where, and this is same with snow, is you can kind of ignore it if you're looking at visually busy things or you're doing something. But then if you're, finally in a area of calm is when the symptom comes more. Same with tinnitus. So it's, I'm lying down at night ready to go to bed, and that's when it decides to really get loud.
What's the difference between snow and like a floater where you see a dot and then it moves out, and then you see a dot and then it moves out?
Yeah. So a floater is actually something inside of the eye. So the gel of the eye is very, very jelly when you're young. And as we get older, it starts to liquefy and the gel is sticky, so it can fold on itself. And so you can get these little folds or wisps that'll just kind of float on by. And we can ignore them a lot of the time, but it's in the eye itself. Visual snow is actually a cortical processing problem. So there's a couple of theories of what it is. Some theories think it's a dysfunction in the higher order processing areas of your vision. So essentially you had damage to the inhibitory signals. So you're actually just hypersensitive now to excitatory signals. And you have this hyper-excitability in your cortex. So things that we normally ignore, you can't ignore because you have damage to the inhibitors. There's other theories of different parts of the brain that are causing this. But at the end of the day, the floaters that you were describing are an eye problem. And the visual snow are these tiny little dots that are a brain problem. So it's nothing wrong with the eye. So by definition, all the eye stuff should be normal in the sense of the retina should be normal, the optic nerve should be normal, visual fields are normal for patients with snow.
I'm going to impress you for a second and pull up your slide from last year.
Ooh, that is impressive.
I love that slide where you talked about the soccer ball. So given this diagram, what you were talking about is processing here, how you were talking about the vision when you see a soccer ball and how it's processed. So when you're talking about snow, it's also a processing within the eye.
Yeah, so it's going to be something beyond that blue pathway, right? So we know that we call it extrastriate, meaning it's outside of the visual pathway that goes from the eye to the occipital lobe. And some people, I think this is where people like, I have a hard time finding information on snow. And this is one of the things I want patients to understand. Nobody understands snow. And every single week there's a new paper that comes out that's like, this is what's causing it. And I personally, and again, not evidence-based, but just based off of treating these patients for so long, I don't think visual snow is one thing. And I think that's why people keep failing to define it, is they're trying to say, like, this is the pathophysiology. We did a case report on 5 people. And the problem with these small case series is that when you don't see a large patient population, you don't realize that all of the etiologies of a lot of them are different. All of them respond to different treatments. They all have different aspects of it. And so I'm starting to wonder, is this similar to headache, right? Headache is a very complicated symptom. And a lot of things cause it. And to truly fix a headache, especially like post-traumatic headache, you have to find the underlying cause. So for some of my patients, they have eye movement dysfunction, right? Ocular motor dysfunction. We've talked about that before. And when they move certain eye movements, their snow gets worse. So when you do the ocular motor vision therapy, their snow gets better. And to me, that's because the ocular motor system was actually what was driving the snow. I have other patients where their photophobia is driving their snow, and we give them some tinted lenses or we do light readaptation therapies. And once the photophobia gets better, their snow gets better. But it's not everyone is different. And even with tinted lenses, we have multiple variations of something called an FL41 or a very good blue blocker of different companies. And I have patients with snow where one lens works, but one doesn't. And so I've had patients where they tried one and another. And we actually have a paper at NABIS this year. We did spectrophotometry on all of the lenses that brand themselves as an FL41, and their profiles are all different. And so
it's not as easy as just getting ordering on Amazon.
It's not. And you'll get these patients like, oh, I tried it, it didn't work. And I'm like, well, I have 15 different pairs. Try all of them and see if any of them works. Because I've had patients with like, that one works, but the others don't. And the frustrating part is they're all expensive. And so if a patient doesn't have a way to try it first, then they're going to have to buy all those lenses and see what works. And so I've been advocating to a lot of my colleagues of like, buy all these pairs. Like, don't just get one, buy all of them and let the patients try them out and figure out what works for them. It's never going to be one fits all because all of them do different things and every brain is different.
That's awesome. All right. There was another topic that you wanted to discuss.
Yeah. So the other topic I really have become passionate about, and I think spend a lot of time in my day talking about with people, is pacing, proactive pacing, and making sure that we give ourselves actual visual rest in our day to prevent our symptoms. So one of the beautiful things about recovering from a concussion is in the very beginning of the concussion, if you're really debilitated by your symptoms, you're not doing anything, right? And so what'll happen is then when people start to feel better, maybe my migraines are getting better, my neck's feeling better, I'm starting to move, you start doing things and you start to get on what we call the roller coaster of recovery, where I have a really good day symptom wise. So I'm going to do all the things. I'm going to do the laundry. I'm going to go to the grocery store. I'm going to go to the gym. And then the next few days, I'm toast. I have all the symptoms and I'm in bed again. And then I have a good day. So I'm going to do all of the things again. They get on this huge roller coaster of symptoms. And you can prevent that if you pace yourselves in your activities. And so a lot of times we spend thinking about how to take breaks and people don't recognize what does a break really mean and how long do you have to take a break. And I think that's been hard, not just for patients, but for providers. So the hardest task that we have right now, because we have return to play protocols, there's no ubiquitous return to computer protocol. And there really should be, because I think that's the hardest task I have for getting people back to school and back to work is what do we do with electronics?
And I joked in our last podcast about my return to Twitter protocol, where there are points where I'm recovering from a concussion, I cannot scroll up and down. And then I can do that way. And I talked about, then the last thing for me is where text goes left to right.
Yep. And so when we do, and I think the hard part is mixed messages from different providers. And so we know for concussion recovery, if something gives you symptoms, let's say, for instance, scrolling up and down, which is a smooth pursuit movement, you're having trouble with visual motion going up and down. For recovery, when I give you rehab, I want to provoke that symptom. I want to make you a little dizzy, nauseous in a very small graded way. So I give you the eye movement over and over. I make you dizzy and nauseous. We take a break. It goes away. And you kind of gradually provoke yourself a little bit every day and it'll desensitize and go away. And that's the point of desensitization rehab. But there's a problem where if you overdo that, then it just becomes aggravation. And so you have to balance, I'm going to do rehab little bits of my day to desensitize it and provoke it on purpose. But I'm going to spend the rest of my day adapting my life so that I'm not aggravating it all day long. So I just don't feel awful all the time. And you'll actually get better faster by not aggravating it all day long.
And if we use the example of, broken bone, or the bone's healed, but you're trying to rehab it, you go to rehab for 45 minutes, you ice it, you heat it, you do little bits at a time, but you don't spend 10 hours a day doing those same actions.
Yeah, I always say orthopedics gets the best break because you get to go into PT and they get to crank away at the knee or the arm or whatever joint they're trying to get better. And then you get a cast or crutches or you get to sit down. And the visual vestibular system doesn't get that. And so that's the biggest problem I have with pacing, which I was saying I'd love to talk to people about, is that we don't give enough credit to how much we use the visual and vestibular system in our tasks of daily living. And so, especially when I have a very high performing patient, I'm a CEO of a company and I'm used to doing 5,000 things on the computer and multitasking. I'm going to do that for 20 minutes and then take a break. And in that break, I'm also going to do the laundry and make the kids lunches. And then I'm going to go and, cook, and then I'm going to meal prep, because those aren't cognitively difficult tasks for them. But the problem is those are very visual vestibular tasks. So instead of taking an actual eye break, you are actually like, I'm going to just stimulate the eyes more. And that's where people get.
And the word rest 10 years ago meant dark room, lying in a bed, which for many people was almost as damaging as the original injury because they spent weeks and weeks doing nothing. And then we just talked about rest not being a bunch of different cognitive tests. So what would rest look like for you? What would rest would you suggest if somebody was, doing an Excel spreadsheet for 20 minutes? What would be the best way to take an eye rest?
Yeah. So if we're doing something where I want you to actually, like, it's a task you want to be doing in your life that's not rehab, then what we want to do is figure out how much time you can do it before you get symptoms. So let's say I can go on Excel for 15 minutes and then I get a headache. So that tells me 15 minutes is too long. And so what I want you to do actually is at 10 minutes, take a break where you close your eyes for a minute, literally just close your eyes. Most people have a lot of stress anyways. So think about your posture, relax your shoulders, and then breathe for a minute and then get back going. And what you can find is doing little 10-minute increments of work. You can get through a whole hour without hitting that headache. But if you decide you're like, nah, I'm going to just blast through this 15, 20 minutes, well, now you're going to have a headache for an hour. And that's not productive at all. So these proactive 1 minute eye breaks are huge for people. And the neat thing is, as you recover, you'll start to be able to push it a little bit. Like initially, maybe you're doing 10 minutes at a time. And then you're like, now I can do 15 and now I can do 20 because your system, you're also doing rehab at the same time, hopefully. So you're actually going to improve your endurance. But we call it visual endurance. So it's kind of like your marathon training. And so you're not going to start day one doing a 26-mile run. You're going to start out doing 2 to 3 miles, and you're going to break at each mile until you get the endurance to get there. And so computer work is marathon training. And then the other thing that we have to recognize is that all the eye movements that we're doing when we're doing things like on Excel, that's a lot of tracking. So something simple like blowing up the screen to make it so that you're not having so many things to look at, or putting pieces of paper on the screen to mask off some of the extra cells, can decrease the cognitive load to make you actually focus. Excel is the hardest. I have a lot of CPAs in my practice, and they're like, I've got all these columns. And so we've actually just had to reformat it so that we put colored spacing columns in between their numbered columns to give their brain like a physical barrier break to help them cognitively interpret it. And it's the little things like that that'll make you so much better. And then the other thing that people are doing now is, which RPT hates as well, bigger is not better. So a lot of people are like, I can't do work on the computer, so I have 2 screens now. And 2 screens is not better than 1 screen, particularly if you've had a neck injury or a brain injury, because usually people are putting their 2 screens side by side, so the middle is directly in front of them. So they're always in a weird head position to one side or the other. Or now you're making more eye movements because you now have split screens. And so it's interesting, but smaller so you want a smaller screen, but bigger font size. And that'll actually make you be able to work longer. But it's been interesting with all of we call it COVID ergonomics, of having people send us a screenshot of what you're doing at work. And you look at the screenshot and you're like, no wonder you have a headache. You have 4 screens, you have, terrible posture, you're in a terrible chair. Like, that's why you're getting headaches. But yeah, so learning to pace and modify your work environment is huge.
I recently had to take a test at a testing center and walked in, and it was a very dim old PC. So it kind of threw me right there. So because of my dyslexia and ADHD, I said, could you, what modifications am I allowed? I was allowed a quiet room, and then they made the font size massive. So it was like this giant font. And there were 18 sentences on each vignette, and there were 75 vignettes and multiple choice questions. So it was exhausting and the PC was probably 3 feet away from me. So I was kind of leaning to the desk. So in that situation, when you're struggling and you have to get through something, what's your suggestion? Smaller font, bigger font?
So I always say it's you have to Goldilocks your way into font size. So there's going to be one that's so small you can't see. So then you end up getting closer to the screen and doing a bad neck position, which will drive a headache. Or it's too big, in which case then it's hard to keep your place because it's so large, and it's hard to almost retain the information because it's so big. And so I usually will say, like, make a paragraph different font sizes, read them out loud, and have someone listen to your fluidity while you're reading. That's what I do in my office. We just do different sizes. And you can hear when it gets small enough that they get slow in reading, and you can hear when it's big enough and they get slow in reading, and then I just put them in the middle. When it comes to computer testing, this has been the hardest thing I've had for kids, because all of a sudden everything's on the computer right now. And if they have trouble with saccades, so making an eye movement left or right, up and down, a lot of kids right now are not perfect typers, right? They have to look at the screen and look at their fingers and look at the screen and look at their fingers to make sure they're typing the right answer in. And a lot of them, I've had parents, when they've been doing work with their kids at home, will say, when I ask the kid what the answer is, they'll say A, but then the kid puts in B. And it's just like a fine motor issue of finding the right letter with their eyes. So a big modification I've been writing for is kid has to have a paper test provided to them. They can't and then not only that, I also say no scantrons, because the same thing will happen with a scantron as the computer of, I actually know the information. I know the letter. I know the answer to this test is C, but I'm having trouble with the eye movements getting to the scantron to put in C. So I always say paper tests, if they have trouble with processing, 1 question per page, and then have them directly circle their answers on the page. If they have trouble, they need eye breaks. They need more time because they need to take time to take a break. And I've also advocated that some people just have someone read the instructions to them, because you can have visual processing problems with concussion. If they have that, and they have good auditory processing, they might not be reading the instructions correctly, in which case you're going to get the whole test wrong just because they're not visually interpreting it correctly. And the simple fix is just have someone read it to them. And if they can read it and then just say the answer, I mean, the point of a test for me, for kids, is to just make sure they know the information so they can go on to learn the next thing. You know, it's not a test of can you visually perform for 2 hours, which is unfortunately really what all computerized tests are now also looking at, is do you have the stamina to do this type of test? And then to your point, the lighting is important. So having overhead glare, but a dim computer is going to make it strenuous to see. So increasing the brightness of a computer, but having a glare screen can be helpful.
That's awesome. Thank you. Just looking at some questions from our support group. I saw my concussion specialist yesterday. He's concerned with my convergence. He's sending me to a neuro-optometrist. Can you explain what just that would be, you know, for someone that has never come in and seen that kind of doctor before?
Sure. So for neuro-ophthalmology or neuro-optometry?
Like, yeah. So if the question is, you know, if I'm being sent by my concussion specialist for neuroconvergence, he's sending me to a neuro-optometrist. Anything I need to know?
Yeah. So number one is, I always say, if your eye movements are provoking your symptoms, expect the exam to provoke your symptoms. So I'm going to look at, why are your eyes not crossing? Are they not crossing because the convergence eye movement isn't working? Sometimes they're not crossing because their eyes can't focus, which is accommodative dysfunction. We call that a pseudo-convergence problem. So for us to figure out why the eyes aren't crossing, we have to do a pretty comprehensive battery of all of your eye movements, and then figure out which symptoms are being provoked to figure out how we can treat you. And so I always tell patients, expect the eye exam to provoke symptoms if that's what's causing your problem. I usually recommend people have a driver for that reason. Sometimes we dilate, sometimes we don't. And that's the same with ophthalmology and optometry. It really depends on the case. There are some people where I have to dilate either because your symptoms make me think there's something wrong in the peripheral retina, or some people, the colored part of their eye over focuses, and that's part of why they're having trouble crossing their eyes. So I have to break that over focus to see what it does to their convergence. So I always say, be prepared to possibly be dilated as well.
Wow, that's fascinating. Eyes are amazing. They really are. And it's just so interesting over the last 10 years how the field itself has expanded. And, you know, where do you think we are with the general practitioner, the general pediatrician, knowing that this is such a part of brain injury / concussion? Are we getting closer to?
I think it depends on the person, unfortunately. And that's I think the hard truth. I think you're going to have some great places. Like, I've talked to the pediatricians at Chopped, and they're with it. They are 100% on it, see the value in eye movements. And I think a lot of it for me is going to be education from their peers, right? An eye doctor can sit on a rock and tell everyone how important eyes are, but I'm a little biased. I'm an eye doctor. Obviously, I think they're important. But I think having other pediatricians talk about the value that they see in doing eye movement assessments and how it's been helpful for them, not only in diagnosing, but treating patients with concussion. Because the nice thing about eye movements is they're objective. And a lot of the concussion things are not objective. And especially when you're working with kids, getting a kid to be able to describe their symptoms, let alone when they have a brain injury, describe their symptoms. I always joke with the parents, but how many times I've had an exam with a kid of like, how does that make you feel? And they're like, fine. Like, what does fine mean, right? You know, how do you feel about this? It doesn't make me feel good. Well, what does it make you feel? Not good. And it's just like you're hitting this barrier of them not having the language to be able to describe how they feel. So the nice thing is, even if they can't describe it, with a good eye movement exam, you can, as a clinician, see it. So you don't even need them to describe it necessarily, which I think is helpful when it comes to concussion and having, especially if have someone who's motivated they're motivated to have a concussion, or they're motivated to not have one, right? So like sports, I'm motivated to go back to play. So I'm going to be motivated to lie about my symptoms sometimes. So having an objective toolkit, I think, is helpful.
And then I have two last things that I wanted to share this slide that you had last time. I thought this was just such a great slide. And if I remember correctly, the symptoms that were boxed were all aspects that could be possibly related to eyes.
Yeah. So ocular motor dysfunction, when it's very subtle, can present as symptoms of dizziness or inability to concentrate or brain fog. Brain fog, we always joke in our office is, it can be endocrine, it can be ocular motor, it can be dysautonomia. So it's one of those things where a lot of these very general symptoms that people have in concussion, the reason it's important to figure out what's causing, particularly eyes, is we can fix the eye stuff. And so then you can get that symptom to go away.
And the other thing along with that is, so if those are the symptoms that we're kind of looking for, when is too early or too late to come in to an eye specialist?
Yep. So it's never too early technically. Well, anyway, I'll take that back. Most of the eye stuff will manifest hours after the initial insult. So it is possible that you go to the ER or you go to your pediatrician too early, maybe within the first few hours of the injury, and then your vision stuff doesn't manifest for the first few hours to days to even up to a week later, where you don't actually get the visual symptoms to arise. So I always say from that perspective, if we can get more pediatricians, because most people, we want you seeing your pediatrician quickly, if we can get them to do the eye movement testing within 72 hours and then a week later to see if it's still there or if it's getting better, that'd be helpful. I know in my previous clinic, when we were working with elite level athletes, they would see me within 24 hours and we would start them on eye exercises in 72 because we were really trying to get them better as soon as possible. One of the big problems we have, though, is there are not enough neuro-optometrists that are trained in true brain injury training to work in this field, to have the ability to get people in that fast, candidly. And so that's the big barrier we have in our clinic, is I'm not going to be able to get someone in 72 hours in. And so what I usually say is be assured that the majority of these will self-resolve usually in 3 to 4 weeks. So what we usually tell people is if you have symptoms in the first 3 to 4 weeks, it should be going away. If you're having persistent symptoms at 4 weeks, that's when you want to start looking at getting in there. Now, I do have some high level performers that will beg in our clinic and, we'll try and do what we can. But sometimes what we'll do is they'll make the appointment for 4 weeks out. And then if they happen to recover before the 4 weeks, they'll cancel the appointment. Because then they don't have that problem of the delay of you call it 4 weeks, but my next available is 4 or 8 weeks out. So there is sometimes finagling with that. But if it's not better within 4 weeks, studies have shown it's not going to get better on its own, in which case we'll have to rehab it to get it to go away faster.
And then when is it too late? When is it you pass this certain mark of 2 years, 10 years, don't even bother?
Never too late. We have patients come all the time, 10 years out, 15 years out, and everyone told them, oh, this is as good as it's going to get after a year. And I haven't found that. Now, I will say it takes me way longer to get them better than if I see them fresh, because they often get these really bad habits as adaptations to having it for so long. So for example, especially the back in the day recommendation of just sit in a dark room, I've had patients come to me for photophobia treatment and they literally have lived in their basement with sunglasses on and the lights pulled or the shades pulled, lights off for 5 years. And they come into my office and they're wearing 4 pairs of sunglasses. And so it's going to take me a long time to get that better because they've now adapted their vision to the darkness and I have to unadapt it to then work on their photophobia. And so it's harder to treat. It takes longer to treat, but you can still treat it. And that's the big thing for me, is there's no cutoff for when it's not going to get better.
That's awesome. And I know that we had talked about the issues then that not being exposed to light affects the sleep cycle too.
Yes, 100%. And then if you're not sleeping, you're not going to be able to see, right? Everything, we always say sleep is the magic to recovery. If you're not sleeping, nothing's working. Your brain's not going to work. You're going to be in pain. You're going to be irritable. So yeah, getting your light cycle regulated is going to be key to getting you to sleep, which is going to be key to getting you better.
Well, thank you so much. That just flew by, but we'll have to do part 4. Great talking to you. And how do people find you?
So they can follow me on LinkedIn. We share a lot of information on LinkedIn for the Concussion Care Center of Virginia or my personal LinkedIn. We also have Instagram, Facebook that we post pretty regularly on. The Concussion Care Center of Virginia also has a really interesting blog that I love people to read. We have a multidisciplinary center and each of us writes a different interesting topic every month. So it's a really fun blog to read.
Well, that's great. And I'll put in our show notes the links to your practice. So thank you so much. I really appreciate your time.
Thank you.
Awesome. That was great.